appreciated.
Okay, just start recording there.
Okay, so I will but I will probably leave in a few minutes. I'll just take a wee note of all the students that are here, and then I'll leave the session. So I'll hand over to you and let you get started. And again, thank you very, very much. And if there's any need for me to come back in, the class rep knows to contact me, and I can easily join back in and answer any questions that need to be answered. But no further ado from me. I'll leave you get on with it.
Thanks, Jackie.
Thank you.
So, welcome along. I suppose we used to do these, we used to visit universities in person prior to the COVID pandemic. And over the last 2 years, we've been reaching out to the 14 universities across the UK and Ireland that deliver podiatry as an undergraduate degree. And you know, they're very, all the universities are very open to Firefly presenting in these virtual visits. So we're delighted that we have this opportunity to speak to you. And really, what we're doing today is we are a commercial company, but this is not a hard sell in any way. We're not trying to sell the benefits of custom-made foot orthotics or Firefly's custom-made foot orthotics, but we're just trying to give you an idea of the industry and the processes and workflows that are involved in the prescription process. I think what we find, and I can't say that this is the case in Glasgow Caledonian, but we find that many of the undergraduate courses, and I've learned this from the likes of James as well, are particularly focused on when you graduate, that there's an expectation that you're going to end up working within the NHS or the HSE here in Ireland, and that there isn't a huge amount of focus on the MSK side of things. So I suppose what we want to do today is to tell you that there is another side to podiatry. It's not purely HSE focused or NHS focused, and that there is kind of a broader scope of practice outside that. And orthotic therapy and the prescription of custom-made foot orthotics plays a large role in that. And that's kind of what our goal today is. So I don't know, maybe some of you might have been on the call last year, and so we did this last year with Glasgow as well. I think we did it with Glasgow, but we had one of our colleagues, Sarah McConnell, present, and Sarah had been working with Firefly for close to 5, maybe 6 years. She has since gone on she's become a lecturer in MSK Podiatry at the National University of Ireland in Galway. And she presented quite a technical, kind of high-end presentation. We're going to take a slightly different tack today, and we are going to, if we just look at the agenda, we're going to have a conversation with James, who's got quite an interesting story insofar as how he got to become a podiatrist. And I think that might be beneficial from me as final year students to hear about James's journey. And then James is going to talk a little bit about quite a short presentation on how we're going to fit this at your workflows.
The workflow in day-to-day practice. I suppose how things work and getting here for me.
Yeah. So some of the theories that you maybe rely on.
Absolutely.
And yeah, things you need to think about, I suppose, in order to do what you do. Okay. Can everybody hear me? Is there anybody that can't hear us particularly well? I think we're okay. Sorry, we're still okay audio-wise, yeah?
Yeah, all good. Thanks, Conor.
Okay. So next up we're going to have a conversation with James Ryan, and then we're going to hear from, here's Kira, I'm going to admit Kira. And then we're going to hear from Sorcha, who's on the call as well. Sorcha is our client support lead. She has extensive experience with Firefly. She would have worked in our operations team and led our operations team in the lab, in the distribution of our custom-made devices to our podiatrists across the UK and Ireland. She now works as the client support lead, where she kind of onboards new customers and she provides them with information around the order process. And she talks to them about the types of products that we supply, the materials that we use. She talks them through our order forms, because the prescription process, if you're unfamiliar with it, James, there's a bit to it, I suppose. Is that fair to say? Yeah, so we've got an order form that has quite a lot of information on it, and Serica's role is really to kind of break down the barriers to ensure that people find it as straightforward as possible to place their order. And just to say in relation to Firefly, so here, this is a little bit of selling, but why not? I suppose what Firefly do differently in comparison to the rest of the other companies that supply custom-made foot orthotics is we offer a kind of industry-leading technical support. And what that means is that, just like that, we have a complicated order form, we've got a lot of options on the order form, but we have a technical support team who are on hand to guide you through that process. So what does that look like if you've got a patient who's in your clinic and you've identified the pathology, but maybe you're unsure about the most appropriate type of prescription that you need to get the patient back up and running again? Well, that's where our customer support and our technical support team come in. We deal with some of the UK and Ireland's leading podiatrists. They're on the phone to us on a regular basis. So from the kind of the most experienced to novices, all rely on our technical support. And what we find is actually those podiatrists who are most experienced rely on our technical support offering more often than those who are least experienced, because those who are least experienced think, oh my God, I don't know what the right question is. I'm afraid that I'm going to look stupid. But those who are experienced, they know that Firefly's technical support team are there for a reason, to answer those questions. And they just ask the questions and they have no reservations about thinking, oh, I'm going to look stupid if I ask this question, because they know that that's the quickest way to get the answer that they need in relation to the most appropriate prescription for their patients. That's the selling over and done it. Yeah, do you know what I'm going to do? I'm going to just take down our little agenda. And see if I can make myself and James. There we go. So we come to you from our recently refurbished Firefly Foot and Ankle Clinic here in Glasgow. And the first thing that we wanted to do is introduce you to James. When did you graduate?
I graduated in May last year.
So how would you describe where are you in your career?
Still very much a junior podiatrist.
Yeah, and how long have you been working with Firefly?
I started working with Firefly in August of 2021. And so I started off in the summer working with the team here.
Okay.
Support team, lead podiatrists in the clinic here, and podiatrists in other clinics all around the country.
Okay. So what we're going to do, although we've already started, is just hear James's story, because I think it's going to be quite interesting for you as final year students to hear about that progression from university to the professional world, and to kind of take on board and just to listen to James's experience. Before I do that, I have to clean my glasses. And I've just identified a little bit of cloth here. So one of the most interesting things I think about James is what he was doing before he became a podiatrist, before the decision to go and study podiatry. So what you kind of had a previous life before this?
Yeah, I did. I had 5 years with the Irish Defence Forces and latterly with the Nations.
Sorry. So say that again. You said
5 years with the Irish Defence Forces and latterly as well with the United Nations.
Okay. So was that 5 years in total?
5 years total.
So in simple terms, you were in the army.
Yeah, I was in the army.
And on a day-to-day kind of basis, what were you doing?
Everything and anything. Logistics, working in offices, every every course under the sun that I get my hands on.
Okay.
I worked overseas in the prison service. Yeah.
And what age were you when you joined the army?
I was 19.
Okay, so you came straight out of school into the army?
Yeah.
Okay. And at what stage did you think I'm going to do something else? Before when you were thinking about I'm going to do something else, were you thinking about becoming a podiatrist?
Not on the slightest.
Okay.
No. So I first got a bit of inspiration, I suppose, for healthcare environment back when I was in my last year and a half of my time in the army. So I had an experience with a multidisciplinary team when I was overseas. I got sick, and just seeing the way that they operated with each other was just, a bit of a spark.
Okay.
And when I came back, I started looking at options, I suppose, for further education.
Okay. I just crossed my mind. So just in relation to the agenda, we're having this conversation now. Then we're going to hear from Sorcha. I never finished this. I have myself. We're going to hear from Sorcha, who's going to go through the order process in relation to Firefly. She's going to talk to you about the products and materials, and she's going to talk to you a little bit about the order form and what that looks like and some of the terminology around that. And when she's finished, hopefully we have time before 12 o'clock. I'll give you a little introduction to some of the scanning software and technologies that we use. So I guess up until about 3 years ago, our customers would commonly use plaster of Paris to take impressions of the patient's feet, or full box impressions. And although those are still quite common means of capturing your patient's anatomy, more and more customers are using scanning technologies, 3D scanning technologies, particularly in concert with iPads. So we have our own unique app for that. I'm just going to show you how that works quite quickly towards the end. So that's our own now. Sorry, I'm getting ahead of myself, and we kicked off before I went through the agenda comprehensively. So, so you identified that you were interested in working in some sphere of healthcare.
Yeah.
So did you then leave the army and pursue that in some manner?
So what I did was I had a couple of different options, threw them up in the air. So I had the likes of the UCAS system in the UK, CAO in Ireland, and then I had the opportunity as well to go back to do a part-time college course to get myself back into full-time education. So I used that as all the access course we have in Ireland, and for the last year of my time in the army, I had two-day weeks as well in college.
Okay, and that was to prepare you to make a submission to apply for universities.
Absolutely, yeah.
So was this similar to doing your A-levels or leaving cert?
Would have been, yeah. Okay, yeah. Just a glorified one over the course of 12-month period.
And you were selecting subjects that were specific to healthcare.
Specific healthcare, yeah.
And at this stage, did you have a clearer idea of what direction you were going to take within healthcare?
I had a general idea, so I was looking at the likes of physiotherapy, occupational therapy, podiatry, and a number of professions. And what I did was I kind of reached out to different professionals in their fields in the northwest region of Ireland. And I sat down, I watched their clinical practice on a day-to-day, and I took notes. So that's where I stumbled across Firefly for the first time. I actually met the Firefly team here when I managed to get in for a week's worth of placement.
So you went and you gained experience in Firefly before you started getting your graduate?
Before you even decided that I wanted podiatry. Okay. And that's where I got the inspiration to give this a shot.
Okay. So in relation to, so then you completed your experience here, and you took on some experience here in Firefly, foot and ankle training, and that solidified your choice in choosing podiatry. Yeah, okay. And where did you go? Where did you study?
I studied in NUIG in Galway.
Okay. And so how do you think that educational experience Well, what we do is, I said earlier on that it's my understanding anyway that undergraduate students are trained for NHS, HSE environments. Would you agree with that?
Yeah, well, NUIG was a HSE funded or sponsored college course. So primarily we were driving us towards working within the HSE, NHS, in the likes of care of the at-risk limb, diabetic wound care, and a number of other pathologies as well that you come across regularly in podiatry practice.
Okay. And at the beginning of the course, was there much MSK influence?
I'd say we touched on MSK from time to time, but I think the first MSK dedicated session that we had was in third year. So a 4-year course. Third year was the first time that we sat down and had a dedicated session with actually an old Firefly pod as well, and so that's the first time that we had full exposure, I suppose, to the world of MSK.
Okay. And was that an eye opener to you?
Yeah, it was. It was definitely a completely different world. We've been exposed, I suppose, slowly, gradually building up from everything from routine care to your at-risk limb and all the different tests and clinical environments that we find ourselves in, and then to toss that all out the window and say, okay, we're going to have a look at just MSK and how the body moves and what kind of influence it can have on the lower limb of the ankle.
So it was a completely different approach to podiatric practice.
Yeah.
Podiatric medicine.
Mm.
Yeah. And what was if you speak about, you said that Adam kind of introduced you to the idea of the importance of how the body was moving.
Yeah.
What was he blind to from a kind of patient? What's the patient was he talking about?
Generally, you can start off with broad brush strokes. So we were looking at different paradigms that's used in the MSK world. The kind of patients you'd be looking at could be anyone from your athlete who runs a regular 5-10K, or someone who's a day-to-day worker who might, do fun run on the weekends. So anything where there might be some sort of biomechanical influence that would cause dysfunction or an issue down the line.
So can I just ask you, like, in relation to what you have done? So you prior to beginning your study, you were in Firefly here in an MSK clinic.
Yeah.
So when you started your undergraduate degree, were you thinking to yourself that didn't align, what you were learning in the undergraduate degree wasn't kind of aligning with the experience that you had specifically in an MSK clinic?
Well, I think there's massive scope of podiatry. So I was just kind of holding my breath and waiting. Maybe I wasn't even, it was kind of in the back of my mind, not until I sat down and had that first MSK session in surgery, was I really thinking about, there's another area in podiatry that I'm pretty interested in.
Yeah.
About trying to pursue this career. So
as you progressed through the degree, did the MSK side of things that Adam was doing, were they in your kind of final exams or your?
To a certain extent, yeah. Again, very generalized questions based around the likes of your biomechanics, but it was a HSE based patient. So
when you were in college, you did placement?
Yeah, would have done, yeah. So 2 different placements that I had when I was in college. One was 4 years in Merlin Park in NUIG. I'm not sure if it's the same for other podiatry colleges around the world, but we had exposure from year 1 to different patients. And they gradually built us up over time. So I was working in Merlin Park Hospital in Galway, and then my final year placement, because of COVID and everything else had been scrapped. I worked in St. James's Hospital in Dublin.
Okay.
So it was a diabetic day care centre.
So both Merlin Park, the hospital in Galway, and St. James's, the hospital in Dublin, similar environments insofar as diabetic foot and wound care.
Yeah, I think St. James's was definitely a bit of an eye-opener. I got full exposure to the multidisciplinary team. So you're working with everything from your doctors, your physiotherapists, your tissue biology nurses. So it was nice to see different professions and how they work and how you can link everything together.
At this stage, are you thinking about you know, if the HSE and the NHS is one route, and MSK is the other route, are you beginning to formalize, or are you beginning to choose one over the other?
Not necessarily. I wanted to have a bit more MSK experience, so I want to dip my toe into everything and see what works for me and what I really enjoy. So we hadn't really had that opportunity to be exposed to it when I was in university. So one of the first things I did when I finished up was started looking for an MSK-based job.
So how, what do you do to try and achieve that? How, so you said at the start that you had made a connection with Firefly.
Yeah.
So that seemed like that was really an obvious route for you to kind of follow once you moved towards graduation.
So well, try to make links wherever you can. So
so I think that's important. How do you do that, or how do you try and create as many links as possible, I suppose?
You basically, well, I still keep in regular contact with a lot of colleagues that I had at college, and find it really useful to see where they are in the world. It's very much sometimes a case of who you know. Sometimes you're introduced to new people, new practices. So I'm kind of communicating with different clinics all around the country.
Okay.
On top of that as well, the likes of Firefly, I've had the opportunity to go to conferences. I've gone to these professional development meets as well, off my own back. So only there a few weeks ago, I was down the country working with podiatrists and physiotherapists in an MSK-based session. And the likes of, you know, even if you don't have that time in your hands, the likes of podcasts and following people on social media, all of that can be available.
What podcasts do you do?
And Podchat Live.
Oh yeah.
It's one of Spotify, it's pretty good. You guys know that stuff.
Yeah, that's no, name escape me. I knew the minute I started saying the sentence, I wouldn't be able to remember it. That's all right.
It's getting me
okay, so yeah, Podchat Live, you get it on Facebook and you get it on Spotify, and they have like, it's probably hundreds of episodes. Just to say, if you have any questions that you want to pitch at James, he's not mad about the idea, but he will field them. Okay, so where are we? So you're in your final year, and you told us that you were gaining experience in St. James's Hospital in Dublin, and you've been in Merlin Park. So let's say you graduated, okay? And before you graduated, had your employment boxed off?
I had employment boxed off. Well, I was talking to a few different people, and I was actually got in touch with Firefly as well to see if they had any opportunities where I could gain a little bit of experience. So I was fortunate enough to sit in an interview with Firefly, and just as I was graduating, I was given the opportunity to join as a junior podiatrist.
So did you have other options?
Yeah, there's the HSE recruitment time, so I applied for the HSE as well. So I got through the panel system, and I'm currently sitting on the panel. So that was another opportunity, I suppose, just to make sure they didn't open doors.
Are you going to leave Firefly?
I don't think so. Picture is pretty well done, so.
Bit of breaking news there. Okay, so yeah. So I think like the important thing to focus on is the idea of building your network.
Yeah.
And there is a bit of there's a bit of kind of, you need to be kind of brave as well to be able to put yourself forward and put yourself in front of the most appropriate people in the profession. So who you think. It does take a little bit to kind of say, I'm going to, even if you're, you know, if you are a new graduate, to seek those opportunities instead of kind of looking on job lists and be proactive, I suppose.
Absolutely, it's probably important. It's just important to be uncomfortable sometimes, you know.
Yeah.
I think that's the way you learn is when you're uncomfortable. Well, that's how I learned it.
And so how uncomfortable was it joining Firefly? Were you thrown in at the deep end?
To a certain extent, yes, but at the same time, I had a really good a really good team here. Everything from ops you're talking about. Everyone in Firefly who's connected with Firefly has support service. They can ring up or get on Microsoft Teams. I can quite literally walk out the door, up the stairs, and walk in everyone just asking them how I'm doing this, and like this orthotic, how should it be designed? Am I going too much, too little? Then I have podiatry leads as well, so I have the likes of Martin, who's the medical director here, and who I do a monthly clinic with. And then I have Greg as well, who's our podiatry lead in clinic here, and he works in all our clinics all around the country, in the UK and Ireland.
So, when you initially started working with Firefly, how were you put on board into the position, and how did that work?
So
they didn't just open up for
clinic.
Yeah, so you were to recruit patients.
Yeah, no, it was fairly gradual response or gradual exposure. So I was working with another podiatrist who was working here at the time, Ms. Gary Seaman, and we did joint clinics together for a few weeks. And then I gradually started to take over, where I was everything from routine care, very straightforward, running through patient histories of patients, working on my notes and see how she writes her notes and how the podiatrists would do theirs. Then eventually that started to taper off. I was at Greg every week or every other week, and then now I'm doing joint clinics with Martin and Greg in here in the clinic side by side with me. So if there's any questions, I can just pop in and ask a question.
Okay. Yeah. So just to go back on what you said a little bit earlier, you're in a somewhat privileged position because in relation to prescription of customary photo products, because the lab is next door, because we've got our technicians who are just on the other side of the building. Although, yeah, so if you need adjustments made, it can happen quite quickly to products.
Yeah.
Do you think that there is a difference in the kind of learning curves between the MSK side of podiatry and the diabetic foot and wound care? Is one more difficult than the other, or are they kind of similar in kind of learning curve requirements?
I wouldn't say one's more difficult than the other, but the approaches are different. So with wound care, if we're just taking wound care for instance, there's a very A to B approach. So you're trying to achieve healing for the patient. So you can do that through multiple different means, but overall we know what we're trying to achieve. With MSK, a little bit different. Every patient is different. So there's a variation on the patient's goals, what the presentation complaint is, and how we're going to address it. So a lot of different roads to the same conclusion, but again, A to B.
What does your average day in Firefly from the clinic look like?
Average day is pretty varied. So I have everything from MSK patients pretty much every day. And so I'd be doing biomechanical assessments. I also do an awful lot of routine cares, and I'll be working with patients as well with the lines of nail surgery. So any issues with ingrown toenails, I take care of that. If there's any other kind of issues through, say, dysfunctional tissues, we use shockwave therapy in Firefly. So say if you have a chronic case of plantar fasciitis, sometimes footwear, activity modification, and orthotics isn't the only thing that will help solve it. We need a little bit of prolotherapy, like shockwave therapy, to help push the tissues into healing. Verrucopetus as well, so any verrucas. We use a mix of different methods for approaching them. Like verrucas, very hard to treat with one particular. There's no gold standard, so at the minute we use the likes of Swift therapy, which is new enough. It's new enough to this clinic. We use salicylic acid. We use debridement techniques as well. So it's very.
The Swift care, what I know it's an offering that has been available in Firefly for my clinic for the last 6 or 7 months, maybe. What can you tell us a little bit more about it?
Basically, what it is microwave therapy. So when we're treating the likes of any plantar warts, and it's
cooking.
It's cooking. So it's not invasive. So you're not causing any physical damage to the superficial tissues, but what you're doing is you're trying to target the dysfunctional tissue in the area of kind of work the verruca and create turnover for the body. So all of these treatments, basically what we're doing is we're trying to trick the body into working for itself.
Okay. And shockwave therapy is something that I know we attend conferences. The Royal College of Podiatry conference, it's quite a prominent product on stands this year in place.
Yeah.
Again, we've introduced it into Firefly Frontline clinics. Can you tell us a little bit more about that?
Yeah, it's been on the go since the 80s. So it was originally designed to help deal with kidney stones.
Okay.
So to help break down kidney stones, and there it's kind of took off from there. So you can basically use shockwave therapy on any tissue. So we can use it for the likes of microfractures. You can use it for any dysfunctional tissues. Primarily, what we use for clinic here is we work with people with chronic plantar fasciitis, any kind of chronic Achilles tendinopathy or tendonitis. If there's any issues there, sometimes it can help just push the patient into an area of healing.
Okay. So we'll begin to wrap up our Q&A session. To try and provide a sense of opportunity for our audience, for our final year students in Glasgow, do you think there are, what do you think of the kind of the state of play in the world of podiatric medicine at the moment from an opportunities point of view, employment opportunities? How would you, yes, that's the first one, do you think there's opportunities out there, a lot of opportunities, or are they growing? And what advice would you give people who are entering into the employment market, I suppose?
Okay. Well, I suppose when we're looking at podiatry, it's at the minute people are screaming after podiatrists. There's jobs left, right, and centre. So there's great opportunity for people to get into the area that they want to experience. There's also great opportunity for podiatry to travel. So you have with the world's your oyster, you can practice in the likes of Canada, Australia, New Zealand, UK, and Ireland, all where we use very similar models. So there's a lot of transfer there. And there's a lot of good clinicians in the likes of Ireland and the UK. There's really a lot of leaders, I suppose, in the world of podiatry that you can pick up their clinical wisdom and work from there. So there's another opportunity.
And advice?
And just, I suppose, make as many contacts as you possibly can.
Yeah.
And and see where it takes you. Even as simple as a conversation with someone, if you're at a conference or if you're at a CPD meet, or if you have a question for someone when they're doing a live podcast chat, you can start to kind of link in with people.
And what about LinkedIn and those kind of social media platforms? Are they things that you use, or would you advise people to reach out and make connections through that kind of?
Yeah. LinkedIn is good. Yeah, absolutely. I have an account that is it's not very active, but no, I do have an account, and it does help you link with people as well. It's in the name,
Yeah. Okay. Any questions for Dave before we conclude this section of our presentation? Any questions about his route to employment, or working in the world of MSK? Over here. So this is from Richie. Did you say microwave therapy for VP? Question mark.
Yeah, I do.
Yes, he did. What's VP?
Verruca.
Penis. Yes, so I did. Hope that answers your question. Isn't the evidence weak for that? Oh, here we go, they're getting technical now. Isn't the evidence weak for that, James?
Well, evidence it depends on the paper that you read. There's still a lot of research being done in the field. Sometimes, like, the most efficacy is shown towards microwave therapy. So therapy can be up to 80% success rate. Whereas when you're looking at traditional means, you can be anywhere between that 30, 40, 50% success rate. But it's just, sometimes with verrucopedis, it's about throwing enough things at it and seeing what happens. I often use simple resolutions as well for patients who are a little bit squeamish, the likes of duct tape method. I'm not sure if you've ever come across it. You can look it up on the NHS website. So it's quite literally popping a piece of duct tape. What you're doing is you're reducing aeration to the area. The glue as well interacts with the tissues there, and sometimes it can go off.
Yeah. I think it's an interesting concept about well, what works and what doesn't work, and even in relation to I think in Firefly foot and ankle clinics, it's about whether we're delivering shockwave therapy or prescribing custom-made foot orthotics. The one answer is not going to work for everybody. But what's important is to be able to provide the patient with confidence and say that we're going to bring you on a journey. So you've got a problem, whatever your problem might be, we've identified what your pathology is or what your issue is. We're going to try this particular approach and this particular therapy, and it has, the evidence says it's got a 60 to 80% strike rate, whatever it might be. But if that doesn't work, we're gonna look after you, and we're gonna, if we can't solve the problem in-house, maybe there's somebody externally that we can bring you to, but that we're going to take you on that journey, and we're going to get you from A to B. We might necessarily have the answer in-house, but we'll be able to, provide that pathway of care. So yeah. Any other questions?
Conor, there was another question put in there in the chat box. Richie asked, is it an expensive treatment?
Is it an expensive treatment?
It's switch.
Yeah, I think we're still talking about microwave therapy. Sorry.
Yeah, it is. So at the minute, it's, well, I'm saying that all of our treatments are all of a similar range at the minute, because we're still introducing switch therapy, and we're still having a look at the results that we can see in clinic. So at the minute, it's the same price as everything else. But we get all our switch therapy heads, every single one of them has to be disposed of afterwards. So we have to get them from the UK. There's a bit of an issue there with the whole
Brexit.
Supply Brexit. Yeah, Brexit.
Okay.
So yeah.
Okay. What about just before we finish up? Being a new graduate and being introduced to the world of orthotic therapy and the prescription process, which Sorcha is going to talk about in more detail. Yeah. And I think you probably get a feeling for the scope of just what is possible, and all the different variables that you need to consider when you're prescribing custom-made foot orthotics. But did you find that was quite, was there a steep learning curve in relation to that kind of aspect of what you were doing?
Yeah, absolutely. Still, ask questions on a daily basis. I think it's the best way to do it. Again, if you take the approach that there's no such thing as a stupid question, and you learn an awful lot.
Yeah. Okay. So just before we finish up, any other questions? It is just 19 minutes to 11. What we might do is we might take a 3-minute break to bring us up to about quarter to just before 10 to. You can get a cup of coffee or whatever you need to do. And we might just come back at 10 to, and then James is going to deliver a short presentation on maybe kind of clinical workflows and some theoretical areas to think about in relation to day-to-day work in clinic. And then maybe in around just after the top of the hour, maybe 5 or 10 past, we will then hear from Sorcha, or maybe closer to yeah, I see that's okay. We'll sort it out. Yeah, okay. So let's take a break for let's say till we'll take 4 minutes, 5 minutes. We'll see you back in 5 minutes. Okay, so we're back. Just what I forgot to do as well at the start of our session was to request you to sign up to our. You can sign up to our mailing list. You can take yourself off the mailing list at any stage. But in signing up to it, you will get some infrequent communication from Firefly, but I'll also be able to send you a link to view this, the recording of this session afterwards. So I'm going to just post the link into the chat. So you can follow the link. I'm just double check it works. Yeah. Follow the link, stick in your first name, your second name, your email address, choose Glasgow Caledonian University from the drop-down menu under university, and select your year of graduation, which I guess is going to be 2002, if you're finding your shoes. But with no further ado, I'm going to hand over to my colleague, podiatrist James Ryan here, who's going to discuss some of his clinical practice workflows for about 10-15 minutes, see how we get on. And we'll take a short break after that, like a 30-second break, and we'll come back, and Sorcha will then present on the prescription process, as she talked about materials, shell materials, top covers that we use in the prescription process for our custom-made foot orthotics. So, you ready to rock?
That's it.
Okay, I'll step out of your way.
Thank you. Okay, so I'm going to have a wee chat to you guys today about some of my day-to-day clinical practice. So I'm not going to be covering the likes of, again, patient history, as you can see in your clinical practice there. And I'm going to be looking at paradigms that we use in clinic here, and just a few others as well that are available to you through the MSK world. We're going to be looking at a few common pathologies. I'm going to just name out a few clinical tests that we use here on a regular basis, and a brief overview of the casting and scanning of orthotics, just from my perspective, and that'll be covered a little bit later on as well. So without further ado, clinical practice. So points to note here, patient history is, again, key. You know, it's gold when a patient walks in the door to you to have a nice history in front of you. The way we do it in Firefly is we actually send out a questionnaire before the patient even walks to the door. And with that, you have all your clinical close questions pretty much taken care of. So when that patient sits down in front of you, what you're looking for is you're looking for them to tell you about a story. So in that story, you want to be looking at their open questions, what their goals are, and what's giving them a little bit of trouble at the minute, and how can we best serve them. Then after that, anatomy as well. You're probably all eyes rolling to the back of your head, even though the cameras are off. Anatomy is incredibly important, and it'll always be incredibly important until it becomes second nature to you. If you even get an opportunity, once you're a qualified podiatrist, if I get 10 or 15 minutes a day, I try to jump into the likes of teachmeanatomy.com just to pass over something I already know, but again, just freshen things up and keep the cogs and wheels turning over in my head. And the next important thing, I suppose, in the clinical practice, when you have that patient sitting in front of you, after you've gotten their story and you have their patient history, is you want to find out what their goals are. So here in Firefly, I'm pretty privileged to have a wide variety of patients through the door. Only in the last month, I had one gentleman come back to me who wanted to beat his PB on marathon time. And another woman as well, a single mother, who her only goal, or very clear vision, was to be able to walk her daughter down the aisle in 12 months' time without the help of advice. So the way that patients' goals are set in front of you, it kind of guides your treatment plan as well and what's to be expected. And the next thing is time management. So again, this is something we need that little bit of time or attention for sometimes. Things that I do to help me kind of keep track of my time management when I'm in clinic is, say if I have a 45-minute consultation for MSK assessment, I have a little blueprint of when I want to have my history take done, when I'm going over non-weight bearing, weight bearing, dynamic movements, a little bit of time as well to talk about potentials of treatment plan, whether that's as simple as activity modification or if we're going for a full ankle foot orthotic. And then note taking as well. So note taking comes in kind of three parts. note taking is really good just to get a holistic approach to your patient to make sure that you're giving them the best treatment possible. Something popped up there. And so the best treatment possible. Another aspect of it as well is just to help guide your treatment plan as well moving into the future. And then the third of all is for your protection as well as a professional in the field. I'm going to jump on to the next one now. So MSK parents. So it's not quite the theory of everything. So the goal, overall arching goal, would be to have no paradigm shift, to have something that you could, as a clinician, walk into your clinical practice and say, okay, this is my set criteria, and whatever the case is that's coming in the door, it's gonna be looked after under this umbrella. But we don't necessarily have that at the minute. Now we have plenty of theories, and there's forever theories being developed and adaptations to the current paradigms that we have. But we have definitely come a long way. So traditions of root theory, you probably all covered it now at this stage. It's one for the history books. Now there's a lot of clinical knowledge in it, and it's always worth to take note of it, and to see as well how far we've come from root theory up to where we're working today. So on top of that as well, we have the sagittal plane theory, facilitation theory, which is something that I use in clinic on a regular basis. So it's concentrated around 3 sites. So you have the rock bottom side of the calcaneum. You need at least a minimum of 10 degrees dorsiflexion between the tibia and the talus prior to peel off. And then we want to look at the metatarsophalangeal joint rocker and have a look at the provided stability there through the windlass mechanism during heel to toe off. Other models that we have, like the Kirby model, the Fuller model, the tissue stress model, which is another one that I use in clinic on a regular basis, and the Dent model. So the list does go on, and it really does give you great scope to approach a patient from day to day. And that all depends on your own knowledge, your own interests, and what you have at your disposal in the clinic. So the two that I like to use at the minute is I'm using the tissue stress model and the sagittal plane facilitation model. And the overall goal is that all roads lead to Rome. So with the two of those, for pretty much any patient that comes through the door, we can have a pretty fair idea of what's going on and how we can best modify their day-to-day to give them a good clinical outcome. Now, so clinical tests. So clinical tests, they kind of branch into 3 different brackets. So we have the likes of our non-weight bearing. Sorry, I'm getting a question in the chat. No.
I don't think there are any questions there, James. Sorry.
No, that's okay. Yeah, no, I'm just after that. Making a small error. There, got rid of it. Perfect. So where was it? Clinical tests. So clinical tests, non-weight bearing, weight bearing, and dynamic movements. So when we're looking at non-weight bearing, these are just a few things that you can run through in a clinical environment. You want to look at your range of motions. Your range of motions can range anywhere from the whole way up into your hip and down to the small joints of the foot. And you just want to make sure there's good fluidity between the tissues. If there's any issues or impingements along the way, you can take note of it if it's applicable to the particular presentation that you have in front of you. Small joints assessment as well. Small joints, again, it's bread and butter to you guys, I'm sure. And you just want to look at the joint movements. You want to have a look and see if there's any inflammation, if there's any homeostasis. You want to look and see if it's nice and smooth, or if it is the timing, I suppose, between the small joints between right and left. You want to look at muscle power as well. That's another very common one that I use in practice, just for practicing if there's anything in particular that is a dysfunctional tissue, you want to be able to cause an area of discomfort in the area. It'll basically lead you to whatever your clinical diagnosis might be. The likes of your favorite test. Favorite test is a good one just for looking at the range of motion of the hip. Maybe one that you've used on a regular basis in clinic, and maybe not. And then leg length discrepancy. So again, these are clinical tests that you can use on a regular basis, but you don't necessarily have to use them for every patient. It's a tailor-made experience. And when we look at weight-bearing assessments, the likes of Jack's test, when we're looking at that first ray and we're looking at the first digit and seeing that dorsiflexion, does it activate the medial longitudinal arch? And is it bilateral in presentation, or is there something that's slightly different between the two? Then you have the likes of your supination resistance test. Again, that's just a good clinical indicator if we're going down the road of orthotics and we want to look at the amount of rigidity that we need in an orthotic device. Foot posture index, now directly linked to the likes of root theory, but it's always a handy one to have in clinic if you're trying to troubleshoot between left and right and seeing if there's any major difference between the two. And then single limb balance, which is something that I've come across, I suppose, recently. I was at a continuous professional development meet there a couple of months ago, and I was talking to a well-practiced physiotherapist, and he's works with an awful lot of runners in the East Coast of Ireland. And he's of a firm belief if a patient can't stand on their foot, single limb tendency for more than 60 seconds, then they shouldn't be running. So again, it's a clinical observation by him. It's his opinion, but there's probably a bit of merit to it too. When we're looking at dynamic assessments, we have the likes of a gait assessment. Now you can have all the bells and whistles under the sun for a gait assessment. You can have cameras, you can have pressure plate therapy or pressure plates, and you can look at this on a treadmill, or you can simply have a patient walking up and down the hall of your practice. So it can be as complicated or as uncomplicated as you want. And you can gain an awful lot of knowledge from the likes of the gait assessment, even when a patient's walking into your clinic for the first time. Then we look at the likes of knee to wall as well. We're looking at weight bearing, ankle range of motion, just to see if there's any blocks or stops. A single squat. Squat's an absolutely fantastic clinical test. You need no equipment whatsoever. It shows you an awful lot about the soft tissue and the bony infrastructures of the foot and the ankle the whole way up into the hip. What we see is that if there's any impingements, any core instability, if there's any issues with the knees, what does the medial longitudinal arch look like when we put it under pressure? That's all fairly useful stuff for bringing you towards a clinical diagnosis. And then we have single leg calf raise. Again, single leg calf raise is a really good clinical indicator. If we're looking at the likes of posterior tibial tendon dysfunction, and what we want to do is we want to see if there is a major difference between the affected limb and the healthy limb. Now, some papers out there say that an average healthy person should be able to achieve anywhere between 25 to 30 repetitions on one leg. I personally haven't seen it in clinic before. I'm not sure if I could do it myself. I haven't given it a test in a while. But again, it's just stuff to keep in the back of your mind. And again, there's a big difference between your clinical practice and what you find on intellectual developers. Okay, to finish up on that, I suppose it's a tailor-made experience. So every patient isn't the same. Every patient that comes into you and sits down may merit some of these tests or all of them, but it really depends on what the presenting client is and how you can best serve them. So, common pathologies that I come across in day-to-day practice. So these are just a few common pathologies that I've come across, and the likes of Severies is very common at the minute, particularly after the two major lockdowns in Ireland at the start of the COVID pandemic. When teams started to come back and schools started to open up again, kids started to go from 0 to 100 very quickly. So more often than not, I've seen it in a range of patients from, let's say, the age of 8 up into 15, where you have an agitation of that growth plate on the calcaneus. Again, when I look at some of the patients that are coming in to me, they're very athletic. So you might have patients that are training anywhere between 4 to 7 days a week. And might be in multiple different teams. There's a lot of movement going on, and then other issues that could be overriding with the likes of footwear. And you can look at posterior chain to see if there's a lot of tightness in the area. Sometimes the child might have gone through a growth spurt. So these are all things I suppose to keep in mind. How we treat it in clinic here, generally activity modification, which no kid likes to hear, is you're going to have to slow down a little bit. So things that we can do as well to help aid them is the likes of strengthening stretching. You'd be looking at stretching that posterior chain, as simple as calf stretch and tiptoe walking. Then when we look at other things we can do, footwear modification can also be a major benefit if we can change things up from their football boots to their daily runners. And orthotic therapy as well, something very simple with heel raising. Other patients again in clinic on a regular basis would be the likes of Achilles tendinopathy and tendinitis, and basically any range of patients you can get on a regular basis come on with these kind of presentations. I've had athletes in, I've had daily walkers, I've had patients who are weekend warriors and they like to go out for a wee walk or a wee run. Overall, what we want to try and do is we want to try and accommodate the dysfunction. So you're looking at, again, maybe some activity modification, trying to avoid walking on soft surfaces such as sand. And you can look at footwear, orthotics, get the heel up a little bit for a period of time just to help with that healing process. And the likes of plantar fasciitis as well is a very common one that we see in clinic. Sometimes it can be misdiagnosed, but typically with plantar fasciitis, you can get an acute inflammation or an acute stage, and you can get it chronic. I'm dealing with a fair few chronic cases now with plantar fasciitis, which have led on from anywhere between 12 to 18 months to 2 years. But through the likes of orthotic therapy, kind of activity modification, the way that a person moves in the day-to-day throughout their house, and shockwave therapy can be quite successful. Morton's neuromas, again, very straightforward one. It's one that you can identify pretty quickly off the bat. So located primarily in between digits 3, 4 to 3. What you get is you get an enlargement of the nerve bundle in between the metatarsals. So what you want to do is you want to identify it again, and be a lateral squeeze test and a motor's click. That's typically where you get it. Sometimes with a little bit of dorsal palpation as well, you can find that sweet spot where the patient is getting a little bit of agitation. Again, for Morton's neuroma, very straightforward treatment plan would be to help widen that toe box. So if we look at the patient's shoes, generally Morton's neuroma, I see a lot of businessmen and women that come in with pointed, tight-fitting shoes that are a little bit inappropriate. They're wearing them for long periods of time throughout the day, and that's when they're getting their high pain is being experienced. So as simple as modifying the footwear for a period of time to help settle down the initial symptoms, and then I suppose you're gradually looking to look after that foot over time. So you could pop an orthotic into the shoe, and you could use the likes of a met wire or a met pad to help offload that area and create a bit of space in between the metatarsals. And then posterior tibial tendon dysfunction, and that would work that foot. So I'm treating 2 patients at the minute with posterior tibial tendon dysfunction, which has led into added work flat foot. Both of them were using ankle foot orthotics for them at the minute, which we use the likes of rigid bracing therapy, which can be quite successful. And we're looking at a very conservative treatment plan for that particular patient. What we want to try and do, I suppose, is try to limit the amount of invasive activities that we're doing. So a brace is a big change to somebody's life, but it's a lot easier than having someone go down the line of surgical consultation and the complications that can spin off from that as well. So casting and scanning, the when and how, I've touched on a little bit already, but a graduated conservative treatment plan is the way that we approach things here in clinic. So you want to look at how you can best get the patient from an area of dysfunction to an area of healing. It might be as simple as changing footwear. It might be as simple as a little stretching, some strengthening. Look at the other things that are linked to the particular pathology that you're after diagnosing. Is there tight tissue? Can you see any other issues that go up and down that posterior chain that might be causing issues for the lower limb? The things that we primarily focus on in Firefly is the likes of footwear and activity modification. We then look at the likes of over-the-counter orthotics. If it's something that can be solved quite readily, we branch then into custom-made foot orthotics, ankle foot orthotic therapy. So what we look at there is we want to be looking at the benefits of the intervention and try and get that foot or that ankle into a zone of optimal stress. That's going to help us down the road, I suppose, when we're looking at the healing process. So if you keep zone of optimal stress, if you keep zone of optimal stress in mind, you can't go too far wrong. So what we use in Firefly, as Conor also highlighted there, is the likes of casting and scanning. So primarily in Firefly at the minute, I'm using a scanning app, and it's an infrared camera we use to take a three-dimensional scan of the foot for an iPad. And for most cases, that's what I use. Now, on top of that as well, I use plaster parts from time to time if it's depending on the patient and the presentation that you have. Sometimes it can be quite beneficial. Foam box as well as another option. I'm sure you've come into contact with both of those over the course of your education, but it's just some of the ways that you can get from point A to point B and develop a pair of orthotics, or looking at an ankle foot orthotic as well. Anyway, I'm just going to pop off for about 20 seconds. I'm just going to get Conor, and he's going to take over. There, guys.
Just if anyone has any questions, you can put them into the chat box for James from that presentation. Thanks very much.
Okay, thank you to James for that. If there are any questions, and I think there might be a question there, so I just need to stop sharing this to be able to see it. Yeah, okay. So I think we are good. Yeah. Okay, you're relieved. Thank you very much, James. Sorcha, are you ready to rock? I will hand over the hosting to you.
Yeah, thanks very much, Conor. Okay, I'll just share my screen. Can everyone see that? Conor, can you see that?
I can't see it.
Okay. For some reason that's not sharing it. Sure. Okay.
Here we go.
Okay, perfect. Thank you.
Yeah, we can see it.
Super. Okay, thanks. Hi everyone, my name is Sorcha, and like Conor said earlier, I am the Firefly Client Development Lead. I've worked with Firefly for the past 8 years. I was previously working in the operations team, and I was the operations and technical support lead. So I do have a lot of experience with the prescriptions and helping our patients and customers out with their prescriptions and to get the best patient outcomes that we can. I suppose what I do now is I deal with the onboarding of new podiatrists. I go through our policies and our prescription forms just to make them a bit more comfortable with our shell materials, our top cover materials, how we apply additions, extensions, and just to make things a little bit easier for them. So what I'm going to do today is I'm going to go through our order form, and I would usually go through this in greater detail in a call in the onboarding process, but I just wanted to have a quick overview for you guys. I don't want to keep you here all day. So I suppose two of the main questions that we would ask when you've decided that you're going to prescribe custom-made foot orthotics for your patient, the two questions are, what are you trying to achieve? And what footwear type are we fitting the devices into? When podiatrists phone into Firefly looking for prescription advice, they're the two questions I always ask. What are you hoping to achieve from the prescription? What are you hoping to achieve from the orthotics? What do you want them to do for the patient? And secondly, what device type of footwear type are they wearing? Because footwear type will have a knock-on effect to the device type that we would prescribe or that I would recommend prescribing. Okay, so for instance, we have, For instance, we have patient info. So this is the first part of the prescription form. So you see column 1 there, patient information. So you have your patient name and address, date of birth, sex, weight, shoe size, footwear type. Patient name is obviously very important. Weight and shoe size are extremely important. Weight plus body weight plus rigidity equals the shell thickness for that patient. Shoe size is required for the top cover length and width of the device itself. I would always say to put the date of birth in because it gives us an idea as to who the patient is behind the prescription. For instance, if a patient was born in 1938 and a clinician has prescribed a semi-rigid polypropylene shell, for instance, I would immediately ask the question, do you think that the patient will be able to tolerate that? Without that date of birth there, we wouldn't know to ask the question. So I'd always say, give as much information as you possibly can to help us in the lab build a picture as to who the patient is. And the same goes for the footwear type, because we can suggest amendments to the prescription based on the type of shoe that we're trying to fit the devices into. Sometimes you may need to compromise slightly on prescription to fit into a patient's footwear that they may not want to, I suppose, alter. But sometimes, a lot of the time, our patients will be really happy to change their footwear style, knowing that they will reap the benefits from their custom-made foot orthotics. And I suppose two of the questions that you will be asking yourself are, am I looking for a functional device or am I looking for a palliative accommodative device? So you'll see there, a functional orthotic device aims to change the load going through the foot. So for this, there must be movement in the foot for a functional device to work. Shell materials for a functional device will be as followed: polypropylene, carbon fiber, 3D printed, and Delrin. If your patient is perhaps older, perhaps have hypersensitivity, they may have rheumatoid arthritis, they may be diabetic, and that's where you're falling into the palliative orthotic device. It's to accommodate an arthritic painful foot or a high risk foot. And in this case, there's little to no movement in the foot, and we must accommodate that patient's foot through cushion cork and EVA devices, such as an EVA device. We have an ORA soft mold, which is a rheumatoid arthritis device. We have a diabetic tri-density device for diabetics. So I'll go through these device types now when I go through the order form. But they're the two questions that you need to ask yourself. Are you looking to have a functional device or a palliative device? Are you looking to control and apply perhaps correction, or are you looking to just accommodate what the patient has at the minute? Okay, so choosing the device type, you'll see that there are headings there: functional, dress, sport, mold, and specialized. So for instance, your functional device, you'll see there standard and direct milled underneath that. The difference between standard and direct milled is actually the manufacturing process that's taken into account. For standard devices that are not direct milled polypropylene, they are vacuum formed, and for every left and right scan, an MDF mold is required, an MDF mold positive is required to heat and vacuum press the chosen shell material. We'll go through shell materials after this, the chosen shell material to the contours of that patient's foot. Direct milled is where the device is actually milled from a polypropylene block instead, so there's much less wastage, and it can be a unitized device, meaning that you can apply the heel lifts in the actual shell itself. So functional device, I would usually, I suppose, explain that as it's your everyday type of footwear. It's for if you have a patient that wants to change their devices from one style of footwear to another. It's kind of your fail-safe really, whereas your dress devices have a much narrower shell grind. It mightn't be as, I suppose, it mightn't be as accommodating for a specific pathology where you will require that amount of shell for the support for the patient. But I suppose if it's a thing that your patient is wearing, things like brogues, things like slimline boots, that's where you'd opt for a standard slimline or a low heel cup slimline. Flat heel cup and Cobra devices, they wouldn't be very popular. The flat heel cup and Cobra devices don't have a rear foot. They don't have a heel cup. The Cobra device in particular is for heels over 3 centimeters. So our most common would be the standard slimline and the low heel cup slimline, depending on what the footwear type is for that patient. And then like that, under the dress, you have direct mill, so you can get a direct milled option of the dress device. And same with the sport, you can get a direct milled option of the sports device. So our sports device is our widest shell grind because it has the deepest heel cup. For instance, our standard functionals have a 12 to 14 mil heel cup depth. Our dress devices have between a 4 and 8 mil heel cup depth, depending on whether you're going for a standard slimline or a low heel cup slimline. But our standard sports devices have a 16 mil heel cup depth, and rule of thumb is the higher the heel cup depth, the wider the device. Your standard sports devices, they would be for trainers. Your low profile sports devices would probably be for lower volume trainers or golf shoes. Impact sports devices then, they are shock absorbing trainer style of a device. But one thing to take into account with the Impact sports devices is that it has an underfill of poron. So underneath the arch, it's filled up with poron, which takes up a lot of room in the shoe. So if it's a thing that you're looking for an Impact sports device, it's definitely something that you need to take into consideration. So we have a soccer sports device. So that's for soccer boots, rugby boots, football boots. Really, it has an hourglass shell grind, which means that it's nicely tapered in the waist or in the mid MLA of the orthotic itself to fit into the narrow MLA of a boot. It's our only device that's per default made from a carbon fiber shell material. The rest of the device types are made from polypropylene shell material, bar our softer devices like our diabetic tri-density or a soft mold and EVA devices. The mold devices then, I would usually describe these as your in between a functional and accommodative device. And what I mean by that is, so for instance, your functional device, your standard functional has a polypropylene shell of semi-rigid. Your RA soft mold, which is our softest device, our most accommodating device, has a rubber flex and thermocork shell, which is really soft, and has a poron underfill, which is really soft as well. So you're going from a functional device to an accommodative device, and our mold device then is our meat in the middle. And how we do that is, instead of the standard semi-rigid polypropylene, we actually have semi-flexible polypropylene. And we also have that underfill of the poron, which increases the shock absorption of the device. So it's your midway between a functional and accommodative or palliative device. Our specialized devices, then you'll see there that it says our diabetic and RA devices can now be ordered using the specialized devices order form. The specialized devices order form is more specific towards NHS trusts who deal solely with diabetic patients and RA patients. There are a lot of additions that can be applied onto those devices, but our diabetic tri-density and ORA soft mold are our gold standard. So I would suggest, if you're looking for a diabetic device or an ORA device, to just write that in the special instructions that is at the bottom left-hand side of the form, of our order form. EVA device, then it's usually a medium density EVA. It's a nice soft device for a patient if that you think that they won't be able to tolerate the polypropylene shell. So it's like that, it's a palliative accommodative device. And then we're on to a really controlling device called UCBL. So UCBL is our most controlling device. It has a 26 to 32 mil heel cup depth. And I suppose it's for the patient who requires the most control. You would see a lot of children being prescribed with UCBLs. But I would suggest, if you're thinking about going for a UCBL device for your patient, to maybe consider the Roberts-Whitman instead, because the Roberts-Whitman, instead of the 26 to 32 mil heel cup, the Roberts-Whitman has a 16 mil heel cup, which means that it'll fit into a more broad range of shoes. But also what it loses in heel cup depth, it gains back with the addition of a medial flange and a lateral flange. So it still provides a very, very similar control level to the UCBL without it being a really, really deep device. So then we have our gate plates. So you might have a patient, in most cases it's children, who you might think are in towing or out towing. And what a gate plate is, it's basically a standard functional device like the top one, except it comes with an extension either medially or laterally, depending on what you're trying to promote, whether you're trying to promote in towing or promote out towing. So that will be our gate plates. Once I suppose the issue has been resolved, we can always grind off the extension, and then it's a standard functional device that the patient can keep wearing without having that extension in there. So after your device type, you do go a la carte, or you can go a la carte. There are a lot of different aspects of our form that you can choose to suit your own needs. There in this picture, you'll see at the top, there are shell materials, and at the bottom, there are top cover materials, or top cover, or our mid layer, or our forefoot extension, or our bottom cover materials. So that's just a little insight as to the materials that we do offer. And then shell properties then. So you'll see there from left to right, we have a direct milled polypropylene. We have Performance RX. We have carbon fiber TL2100. We have Delrin, which is a direct milled material. We have polypropylene vacuum formed, and we have XT Sprint. And I'm going to go through these further in detail. It's nice to see a picture of the differences between them. So like I said, going a la carte, so our shell materials. Our most, I suppose, common shell material would be polypropylene. It's really good for adding things like DELs. It's really well tolerated by patients. There's a lot you can do with it. You can reduce the heel cup, you can grind off extensions, kind of things like that. So polypropylene would be our most popular. Then you see Performance RX there. So Performance RX is your middleman between your polypropylene shell and your XT Sprint and TL2100. So it's your middleman between polypropylene and carbon fiber. Performance RX is a really lightweight, it's very durable material. It's really thin, no matter whether you choose rigid, semi-rigid, or semi-flexible. It's approximately 3 mil for either of those. The one thing to take into account is that Performance RX does have limitations when it comes to deep heel cups. We can't apply any facial grooves, we can't apply any sweet spots because of the properties of the actual material itself. Then we have our two carbon fibers. So we have XT Sprint and TL2100. So XT Sprint is a really good shell material for active patients. There is that bit of flex in it. And that's why it's the default for our soccer sports device. And it doesn't take up as much room in the shoe as your polypropylene would. So it's thinner than polypropylene and it has a bit more flex. Then we have TL2100, and that's a really, really rigid shell material. And that's just something to kind of keep an eye on. if it's a thing that you prescribe TL2100 for a patient who is potentially too light for it, there you will get intolerance issues. You get blistering, you get issues because it's a really, really rigid shell. I suppose for perhaps the heavier type patient is where you'd go for your TL2100. But what we've actually designed is, it's called Delrin. It's a shell material that's direct milled, and it's specifically been made for obese patients. Now you can use it for other patients if you want to keep your volume down in the shoe, but it's been specifically designed to hold approximately half the thickness of polypropylene and to give the same amount of support. So that's just a really interesting shell material that we have. And what's not included in there is our 3D printed material. So 3D printed is, we make it from our sustainable PA11 material from the castor plant, and that's really popular at the minute as well. I suppose, you know, that's where kind of things are going. They're going towards digital, they're going towards sustainability, and anything that we can reduce wastage on is a plus for us. Rigidity then, all of our devices are semi-rigid, bar our mold devices are automatically semi-flexible. However, this is your menu. You can choose what you want, whether you think the patient would be able to tolerate a semi-rigid device, or if you think that we could, or that they'd be better off with a semi-flexible device. It's completely up to you and what you've decided in your biomechanical assessment. If you're not sure, we can always go through the prescription with you. It's something that we do on a regular basis with our customers. And as Conor said earlier, I suppose it's our most experienced podiatrists are the ones who lean on us most. And definitely that's kind of what we want. We want our newer podiatrists as well to feel like they can lean on us the same way that our customers for years have done. Fill materials then, so that's what I was talking about earlier with the underfill. So underneath the device is filled up with Poron, cork, or EVA. You wouldn't really see a cork fill. It's really, really rigid. So it's really if we need to stiffen up a device, but in a lot of cases, the EVA would do that for us. Poron then is applied as an underfill for shock absorption. Then we have our forefoot extension. So that's material placed at the distal edge of the shell to either the sulcus or to the toes. So if you want extra cushioning in the forefoot only, but you don't want to apply any bulk on the shell itself, it starts the distal edge of the shell to the sulcus or to the toes. So you see there are 4 options. There's Poron, there's Niplex, there's cushion cork, and there's puff. Wherever you see puff with Firefly, it's actually EVA. It's just what we call EVA. I suppose Poron is our gold standard for cushioning. If it's a thing that you're looking for cushioning, we will always go for the Poron or suggest the Poron. Niplex is a shock absorbing material. Cushion cork then and puff or EVA is for stiffening up the forefoot. So then we have top cover selection. So vinyl, it's really thin, it's really wipeable, it's long wearing. Leather, microswed, and WSL carbon, there are premium top covers, so they actually come with a surcharge. Neoprene is our default for our standard sport. It's really cushioning. It's that wetsuit material. It's really cushioning, it's durable, and it comes in 3 mil thickness. Plastizote is a really, really soft material, but it's very porous. So it's something that would be on our diabetic devices. Puff is EVA. And Bambulon is a material that's been specifically designed for patients with hyperhidrosis. So it has antibacterial properties in the actual material itself. But one thing to note is that if you prescribe Bambulon, it will require more frequent refurbishments than your other materials because of the properties of that material. And then you have your combined material width. So that's basically you're looking for a mid layer of cushioning of Poron, either 1.5 mil or 3 mil. And it's really important then as well to tick the length of the device that you're looking for. Bottom cover devices or bottom cover selections then, we apply bottom cover automatically for every device that's longer than a met length to protect the top cover, to protect the additions and extensions you might have asked for, to protect the mid layer. And there are just some options there that you can apply. Posting section. So posting section is probably one of the most important parts of the prescription. It's how you want to correct the device. So you see there's a couple of options. So you have lab evaluation. That's basically you telling us, I don't know what to do with the prescription. I need your help. And then you give us as much detail as possible and we ring you and we discuss the prescription with you. Then we have measurements from vertical. So that means you want us to correct the cast to vertical. And then you want to apply rear foot posting so for instance, if you think there's rear foot extrinsic, intrinsic, left and right, say you apply 3 degrees varus left and right, you want us to correct to vertical and then apply the posting. So really it could be looking at maybe 5, you could be correcting to vertical by adding 2 degrees, and then you want 3 degrees correction from that. So it's just something to take into account. Our default for our posting section is if nothing is ticked, it's correct to calc vertical, balance the forefoot to the rear foot. So if you had kept that as blank, that's exactly how you'd get it. Calc vertical would be, I suppose, for the majority of your patients really. It'll be your pes planus foot type. So anyone you want to apply a little bit of posting on. Neutral would be different. So neutral, I would suggest or recommend for pes cavus foot type, or if a patient has hypersensitivity and you don't want to apply any postings there, that's where neutral, as I said. So we're not adding posting to get it to vertical. So we're keeping it exactly as you have captured the foot. So rear foot then and forefoot posting. So the difference between extrinsic and intrinsic is that extrinsic has an EVA support post in the rear foot. All of our posting is always applied in the shell, whether that be rear foot or forefoot. The only time I suppose you'd have an extrinsic forefoot post would be if a patient has a true forefoot varus, or if a patient has a really severe cavoid foot type and you want to follow the correction through from the rear foot to the forefoot. A skive then, that's the Kirby skive. They're usually medial, but you can apply them laterally. Inversion is basically inverting the entire device. So if you're adding 3 degrees of inversion, you're not only adding 3 degrees in the rear foot, you're adding 3 degrees in the forefoot, and it actually sits up off the ground. Whereas in our rear foot section, in our rear foot posting, we bisect the rear foot, so that doesn't do that. Motion then is a grind off of the EVA rear foot post to, I suppose, to promote rocking in the shoe. It's not, inversion and motion aren't very popular. They're not kind of widely requested. Okay, so this is just a couple of images there. So posting to vertical, so you'll see there the left cast and the right cast, they've been marked at vertical. You'll see the left cast is almost sitting at vertical as it is, whereas the right cast, we might need to add 3 degrees to get that to vertical. So when we're scanning them, that's kind of a level of degree that we would have to add on the right, especially. Posted to neutral, so that line there suggests that that's where the vertical line is. But if you're posting to neutral, you're scanning it exactly as it currently is. We're not applying any wedges to get that vertical line vertical. So they're just, I suppose, visual representations as to vertical and neutral and what they look like. And this is the intrinsic versus extrinsic. Like I said, all of our posting is applied intrinsically in the shell. The only difference between extrinsic and intrinsic is that the extrinsic, it comes with that rear foot stabilizing post. And then this is just a little animation on the varus and valgus posting versus a skive. So you'll see here on this illustration, so this is, I suppose, the effect that a varus post would have. This is the effect that the valgus post would have. And then you'll see a much more aggressive skive application. So skives are much more aggressive than your rear foot posting. Okay, I'm just looking at the time. Okay, so cast dressing is basically the distance between the orthotic and the patient's foot. Minimum is our default. If a patient has a lot of tissue spread, or you need to allow for lateral heel expansion, you go towards your moderate and maximum. If you require a tighter fit, a total contact device, that's where you go for your type 1 or skin. Sorry now. And then modifications. So based on the biomechanical assessment, you would choose modifications to determine how, like going back to the first question, what are you trying to achieve with the orthotic? So heel cup depth that you want to fit the devices into, first met, first ray cutouts, rigid first extensions, flanges, shell grinds, whether you wanted a narrower shell grind to fit into a certain type of shoe, whether you wanted a wider shell grind to have more surface area for a specific pathology, facial accommodations, that's the facial groove for the plantar fascia, heel spur accommodation, heel holes, sweet spots. Sorry, now I'm just seeing there's a chat there. Oh, sorry, that was just from Conor. Heel holes, sweet spots. So sweet spot is a dell in the shell that will allow for bony prominence to sit into. For instance, your navicular, medial cuneiform, base of first met, base of fifth met, styloid process, cuboid area. So it would be pushed out almost from the shell material, and that cavity then will be filled with poron. So the patient's bony prominence isn't being hit from the shell, or isn't sitting down on the shell. Then we have additions. So these are all as well, these are all the illustrations there on the left are really helpful to let you know where they're placed, where these additions are placed, and kind of what they're for, and what area they're for, what area you want to offload. So all of these then will be kind of coming back on your biomechanical assessment, and what you want the devices to do for the patient. And okay, sorry, now I just kind of rushed through that last bit. I know that we're kind of cutting it fine with time, so I
take your time, Sarah. You're doing okay.
Oh, sorry, yeah, thanks, Conor. But yeah, so thank you for listening. I'm happy to answer any questions anyone may have.
So thanks for that, Sorcha.
Thanks, Conor.
See if anybody has any questions. So it's quite extensive, I guess. I think it's also from like generally speaking, Sorcha, it's probably worthwhile talking a little bit about different terminology that might be used between different labs that kind of means the same thing.
Yeah.
So would it be fair to say that we in Firefly are heavily influenced by the kind of North American model in relation to custom-made foot orthotics?
Yeah, absolutely. Yeah, that's kind of where our fundamentals have kind of come from, I suppose. And that all stems from Martin, the medical director of Firefly. He was obviously taught in the UK. However, he has adopted a lot of the North American paradigms to try and translate it over with the UK I suppose practice, but yeah, definitely we are heavily influenced by that North American market, I suppose, even their terminology and things like that. But what we do is when I am speaking to a new customer, if they have ordered from a different lab, I will ask them questions like, what shell materials did you use there? What top cover materials did you use there? So I can figure out what close alternatives we have, or if we have matching materials. Also, they might say, oh, I always order a Cobra pad. We don't have Cobra pad on our order form, but by knowing that they always order a Cobra pad, I'm able to explain to our team, this is what they mean when they ask for a Cobra pad. So that initial interaction with a new customer is really, really important to figure out how we streamline everything and how we go through terminology, kind of things like that, and how we translate into our orthotics. Because like I said, I know I said earlier, the only difference between extrinsic and intrinsic is extrinsic has an EVA stabilizing post, but on a lot of different in a lot of different labs, they do it differently. They might add posting physically, so they might, and then a customer then might expect to see that. Whereas if I didn't say that from the get-go, if I didn't have a call with them from the get-go, they're expecting something that they're not getting. And I suppose that's why we say for people to lean on us, especially at the beginning of their journey with the Firefly community.
Just really quickly, Ryan, I know we're a little bit tight for time, but just a question in relation to, and if anybody has any questions for Sorcha, they can post them into the chat there, or you can unmute yourself and just jump in with a question. But also in relation to the kind of management of patients post fitting of device.
Yeah.
So it is not unusual for the podiatrist to fit the orthotic when the patient returns for a fitting session, I guess.
Yeah.
And quite commonly, small adjustments will be needed to be made to the device.
Absolutely, and that's completely normal. These are custom-made, hand-finished devices for a patient-specific pathology. For instance, we might need to add extra posting. We might need to remove a little bit of the posting. We might need to make small tweaks. And we actually do have an 8-week free of charge adjustment period. And it's a bit of a fail-safe really for podiatrists who are perhaps maybe not as confident in their prescription, to be able to have that fail-safe and something to fall back on if it's a thing that they may have overcooked or undercooked the prescription, or if a patient, or if say a clinician has prescribed a met pad for a patient and the patient really doesn't like it, they can just send it back, we remove it, and it's simple as that. I suppose, and we don't want to punish anyone then by charging the clinician, charging the patient for this little tweak. So that's why that 8-week free of charge adjustment is really important, and really, I suppose, it is greatly utilized, and especially by newer podiatrists who are just, I suppose, getting used to our products, and I suppose the way that we work and the way that we apply additions and extensions and all that.
Quick question here from Aaron Skinner. How long does it take to receive the orthotics normally, or to receive changes once requested, or to implement changes? So yeah, turnaround times, I guess, Sorcha.
Okay, so turnaround times for our custom-made foot orthotics from receipt of initial order to dispatch is usually 10 working days, but at the minute we're running at 12 working days. For, I suppose, modifications, if you had fitted the patient, or if the patient had come back for a review and you wanted to tweak them within the 8-week free of charge adjustment period, just to note, I suppose, after the 8 weeks, it's not that you're just fallen off the face of the earth either. After the 8 weeks, between 8 weeks and 6 months, it's a £15 change of prescription fee. So it's still not a massive charge if you need to make any tweaks after that. But the turnaround time then for the modifications is between 4 and 6 working days from receipt to dispatch.
Okay. Any other questions before we wrap things up with Sorcha? So what I'm going to do, just until I'll bring us up to 12 o'clock, is to give you a little preview, a little overview of our Fusion app. So I think I said this already, but traditionally podiatrists will capture their patient's foot anatomy for custom foot orthotics through plaster of Paris casts. Do I have an example here? No. Or a foam box. No example here either. I should have thought that. But you would have seen, I think, was there some images that you had, Sorcha, of casts?
Oh, yeah, I can.
Anyway, the point is, traditionally these kind of older methods of data capture were used, and there's nothing wrong with them. However, if you're capturing your patient's foot anatomy with plaster of Paris or foam boxes, it means that you've got to, if you're a practice manager or you own your own practice, you've got to keep these materials in stock. So you've got to keep your rolls of plaster of Paris in stock. Capturing anatomy with plaster of Paris takes probably about 20 minutes. You've got to get the patient in position, apply the plaster, you got to let it dry, you got to box it up, you got to make sure that it's 100% dry before you box it up, and then you got to bring it to the post office. You got to cross your fingers and hope that Royal Mail look after your box so that they don't kick it around the place and it doesn't get bounced around too much in transit between the UK and Firefly. So there's a little bit to it. So about 2 years ago, we set about in Firefly creating our own app. Now there's lots of different scanning apps out there. So obviously if you can capture your patient's foot anatomy in a digital manner, you can speed up the order process because you don't need to, well, you can speed up the process in clinic because you can capture your patient's anatomy in 30 seconds instead of waiting 20 minutes if you're using plaster Paris. And you don't have to go to the post office. So you don't postal charges either. So I'm just going to share my iPad screen and just show you what this looks like. Oh, do I need to take back hosting? I do. I do need to give hosting to me. You're muted now, sorry. Oh, I wonder if it's because I'm not
You should be the host now, Conor.
host, yeah. Oh, no, I'm an idiot. I'm an idiot. There we go. Okay, so here's the app. So this is the dashboard of the app on the top left-hand side. You've got. So this app works with. Can you still see my camera, or is it just the iPad? Can you see me as well, Sorcha, or is it just the iPad screen?
No, just the iPad.
Okay, so I'm going to stop sharing. So this is your iPad, and on the iPad you've got your scanner attached. So this is a structure sensor scanner, and this piece of hardware is required to capture the patient's anatomy, and it attaches to the iPad through this cable that runs from the back of the scanner, and the scanner sits in a bracket. And start sharing again. I'm going to race through this. And when you log into, here we go. So when you log into the app, this is what you see. You see the dashboard, you've got the battery status for the scanner, it's got its own power. This is the iPad battery status. Down here, we've got all my patients that are listed, got different statuses for the different orders. So if they're incomplete, they're missing a scan, or the prescription hasn't been completed. If the status is in review, it means that the order has been submitted to Firefly, but we haven't started manufacture yet. If it's shipped, it means that the order is shipped and it's on its way back to the clinician. Submitted means that the order is being manufactured. So this is what a podiatrist sees. So all our clinicians across our Firefly foot and ankles, they use the Fusion app on iPads to capture the patient anatomy. And I just very quickly demonstrate how easy it is, how quick it is to capture the anatomy of the foot. So this is the main navigation menu on the left-hand side. We're in the dashboard at the moment. If we tap the scanner, it tells us to enter a patient name, and we say test 1, 2, 3, 4, 5, 6, 7, 8, 9. So I'm entering in the patient name, which obviously won't be text 1, 2, 3, 4, it'll be whatever the name is, and you hit set. And immediately you are presented with a banding box. So here we have a foot on the table, and you can see here you want to put your patient's foot within this kind of banding box area, and I can change the size of the banding box. And this banding box, you can see the larger rectangle and the rectangle at the back, step away from the table, is the three-dimensional space within which you want to place the target object, i.e. the foot. So we'll go back to the foot, and you can see there's different colors here. Before we start the scanning process, if I'm red, I'm too far away from my target object. If it's blue, you're too close. So you want that green rendering on the plantar aspect of the foot, and you want to make sure that the entire foot is in the bounding box to make it slightly bigger. You can see here we are capturing the left foot. So it looks like I've got a right foot here. So I'm putting the wrong foot in the left foot container, but this is just for demonstration purposes. And you want to be about half a meter away from the patient's foot. And once you tap the scan button, very quickly, it starts capturing the data. And you're simply rotating around the patient's foot. From the left, to the right. And then I'm going to tap the end scan button in the bottom right-hand corner of the screen. Say that I'm done. It will automatically produce a preview of what you've captured, so you can have a look to make sure that you've captured all the anatomy that you need in order for the custom-made foot orthotics to be manufactured. And when you're happy, you just hit end preview. It will automatically jump you into the opposite foot container. So we're going to capture the same foot again for demonstration purposes. But you can see how quickly you can capture the patient's anatomy. It just takes seconds. Put her in the back. And scan, it'll show me my preview. And I'm happy with that. And the next thing that I'm presented with, if I tap the order form button, is a digital version of Firefly order form, similar to what Sorcha had brought you through earlier on. And you literally fill in the order form as per your requirements. Some pieces of information are required in order to process the order, like the patient's weight, we'll say 88 kg. You have to put in your shoe size. This information is critical in order for us to be able to manufacture the product. Let's say it's a size 8. So you can see here there's other information. You can put in the patient's gender, but it's not required. Foot type that the orthotic device is going to go into is not required, but it's very helpful for the lab and the manufacturing process to know that this is going to go into a set of, let's say, rows. And we just progress to the next page. We can create templates here that populates the order form with prescriptions, kind of go-to prescriptions that we might have for different device types. We might have a kind of a go-to functional device that we always choose a pour-on top cover or a puff top cover. So you can save your templates, which will just make the order process much faster when using Fusion Up. We need to pick our device type. We'll say it's a functional device. This is a bilateral order for the left foot and the right foot, but it could be just for the left foot and the right foot only. We're going to order 1 set. We're going to order up to 10 sets. We're going to choose our shell material. We're going to say it's a polypropylene, which is kind of standard for a functional device, semi-rigid. And you can see here that in the optional specs and additions, we've got 1, 2, 3, 4, 5, 6 different tabs. So you can really get as granular as you require to make the most appropriate, or to design the most appropriate orthotic for your patient's needs. And really, this order form is just a series of drop-down menus, and you just choose what is appropriate. Cast dressing, so I explained all this to you. Here's your different options. We're minimum by default. So I think what's important to note though is you can so we issue all our customers with our catalog, which is also on our website. So you can just choose a device type and you can leave it like that, and we'll make the device to the spec, the default spec as per our catalog and website. Or as I said, you can get as granular as you like and add as many additions and modifications as appropriate for the pathology or for the patient's footwear or their needs. The last thing you do is you jump to the very end. So the penultimate page gives you just an overview of the prescription that you've created. You can just review that. And then we'll skip to the last page. And we choose our ship to address. We can ship to the default ship to address, which is usually the podiatrist clinic address. You can ship it to the patient address if you put that in at the start. Or you can ship it anywhere else in the world by entering details here at the end. But we'll say let's ship to this address here. And we just hit the submit button, and if we're connected to the internet, it should say order sent. Here it is. Oh, it's pending. Oh, there we go. it's sent. Let's try to find it here now. Here we go. So it's order number 56648, and it's in review, which means that it's been successfully received by the guys in our operations team, but they haven't started manufacturing yet. So if this patient comes in 2 months' time and they want a similar set of devices for football boots or trainers or whatever it might be, I can just tap the reorder button. That will launch the prescription form. I just need to change the device type from functional to sport appropriate device and design, and I can quite quickly reorder second sets. So that is a very quick summary as we reach 12 o'clock of our Fusion app. Just to give you an idea of what's out there in relation to anatomy capture, and that it's not all phone box impressions and plaster of Paris casts. Any questions before we finish up on that? So that's the Fusion app. You can download it. It's free to download from the Apple App Store. It's only available on the Apple App Store. It's not available on Amazon or on the Google Play Store. And that is because the structure sensor is compatible only with the Apple iPad. And so that's the reason for that. So just before we finish up, I'd encourage everybody to fill in the little contact form so we can send you a recording of this session. We can also get a little bit of a feedback from you after the event to see how we got on and whether the content that we provided was useful for you or not, so we can continuously improve. So if there are no further questions, I'd like to say thank you to you, Sorcha.
Thanks, guys. Thanks for listening.
You're muted.
Shouldn't be.
Can't hear you.
Oh, thank you.
She said thank you anyway. Here's messages coming in. Thank you, thanks. Okay, thanks Danielle, thanks, and Louis, Richie, thank you. Just to say very finally, if you're in the northwest of Ireland and you fancy visiting Firefly Custom-Made Foot Orthotics and our lab, you're more than welcome to. We regularly, well, prior to COVID, we regularly host students, and we're happy to show them around the lab. Introduce them to our podiatrists, introduce them to our technical support team, our operations team. And yeah, I think that's a wrap. It was a pleasure to talk to you. We hope it was informative, of some benefit. You can contact any of us at any time if you have any questions. My email address is conor@firefly.ie, CONOR@firefly.ie. Sorcha, will I give out yours?
Yeah.
You can contact Sorcha. Pronounced Sorcha, spelled SORCHA, @firefly.ie. And I think the major takeaway is we're here for you if you have any questions in relation to prescriptions or any relevant questions at all. So on that note, thank you very much. We really appreciate the time that you've given us, and we look forward to catching up with you in the future. Thank you. Have a good day, guys.
Thanks, guys.